Anyway, so this is part 2 of the series we're covering with regard to osteoporosis. And I mentioned before, some of what I say is going to be covered in more detail by other talks, but also we'll go into detail in other areas. So let us start. And I'd like to discuss, this may seem very simple, but you need to have a pretty clear understanding of what we mean by vertebral and non-vertebral fractures, because as I mentioned earlier, the major clinical endpoint of all of the clinical trials that have led to the approval of the drugs we have available is the vertebral fracture. The FDA, from the point of view of approval, that's all they need in terms of efficacy, vertebral fracture efficacy. Obviously, you have to prove safety and efficacy. But in terms of efficacy, it's vertebral fracture. Non-vertebral fractures are not required in terms of efficacy for approval of drug. But non-vertebral fractures have become an important endpoint because many of our drugs also reduce the incidence of non-vertebral fractures. And when you're thinking about osteoporosis, obviously you want a drug that will be effective at both vertebral and non-vertebral sites. If you look at, on the left, the bar graph that says osteoporotic fractures, there are 2 million. And you, as I indicated earlier, if you compare it with events such as heart attack, stroke, and breast cancer, obviously the number of fractures far exceeds the number of heart attacks, strokes, and breast cancer. And of the 2 million fractures, about half, give or take, are vertebral fractures. So there are 2 different presentations of vertebral fractures. Vertebral fractures can appear as sudden, severe back pain, and it can be just getting up from a chair. I have a dear friend in my field who I saw a couple weeks ago, and he was really hobbling. I said, what happened to you? And he said, I was just sitting at my desk working, and I just turned to get up and couldn't get up. I mean, I was severely in pain. It often requires immediate medical attention. Sometimes it doesn't. Sometimes it isn't even noticed as an event. I have a little bit of back pain. We all have back pain from time to time. It can be an incidental finding on an imaging, like, for example, the lateral, as I mentioned, the lateral chest x-ray. It may be just discovered. It can be a change in physical appearance. A patient called me the other day and said, Doctor, I have to see you because if I don't see you soon, I won't be any higher than the table. And another patient who said, Doctor, if you don't do something for me, I'm going to be buried in a shoebox. It can change shape, kyphosis, height loss. As I mentioned, the GI tract is affected. And it can be insidious, not in an acute event. So I like this picture. This former very famous woman, Liz Taylor. And this came from one of our major newspapers in New York, the National Enquirer. Actually, it's not just New York, it's all over the country. Most of what's in the National Enquirer is not true, but most of our life these days are dealing with truth and untruth. We've lost the distinction between truth and untruth. We're going to have to splice that comment. Anyway, this illustrates what happened, allegedly, to this woman. She was lying in bed, reached for something, and let out a horrifying scream. She had broken her back. And the diagnosis was said to be 2 vertebral compression fractures, and she had vertebroplasty. So, so that can happen. But the other presentation is actually the more common presentation. And the late Pope John Paul II, obviously, he had vertebral compression fractures. And so either an acute event or an insidious event. But whether it's back pain, loss of height, deformity, reduced pulmonary function, diminished quality of life, and increased mortality, these are all features of the vertebral fracture. Some people have made comments about the so-called morphometric vertebral fracture. That's the X-ray you discover by X-ray. And incidental finding. 2/3 of vertebral fractures are discovered that way. Only 1/3 are the event. But it turns out that all of these points, including increased mortality, occur to the same degree, whether the patient has sustained an acute event or this sort of subclinical event. So we have the clinical event, we have the X-ray finding, and I mentioned just a moment ago that 2/3 of these events are not events as such, but they're discovered incidentally by the X-ray. Now, to contrast the vertebral fracture is the non-vertebral fracture. And the non-vertebral fracture is almost always a clinical event. Can you imagine breaking your hip and not knowing you broke your hip? Or breaking your ankle or your wrist? Most of the time, if not all of the time, a non-vertebral fracture is a clinical event. So of the non-vertebral fractures, the most important is the hip fracture. And the hip fracture is occurring some number, 300,000 hip fractures per year. And we have said before, and will continue to say, that the broken hip is not just a broken bone. There is an increase in mortality of upwards of 20% in the first year after that hip fracture. 30% of these individuals have some kind of permanent disability. 40% are unable to walk. Hi, Tara. Welcome. This is Tara Keshanova, and Tara's going to join us. She came early for the show, as you put it last night. Well, join us.
Sure.
I'm not ready. We're not ready for you yet, but we will be ready for you soon. So we're talking about vertebral and non-vertebral fractures. And we're discussing the hip fracture and how the events after the hip fracture are related to mortality and morbidity. 80% of individuals who have had a hip fracture are unable to carry out at least one independent activity of daily living. So we also have to consider the other non-vertebral fractures. Often, when we say non-vertebral fractures, we're including the hip, but of course we take the hip fracture as a separate non-vertebral fracture because it is the more important one. But nevertheless, you do have to consider, when we consider clinical trials, non-vertebral fractures. So literally, any non-vertebral fracture is a fracture that doesn't include the vertebral spine. But that's really not true when we're talking about clinical trials. We've talked about traumatic versus non-traumatic, and that's still often not clear, but most of the clinical trials define it as a fragility fracture, not all comers. So again, when you're reading papers about these clinical trials, we always exclude, almost always, the skull. It is a non-vertebral site, but when patients have a skull fracture, we do not count it as a fragility fracture or as an osteoporotic fracture. We do not count fingers and toes. So a digit fracture occurs. And you may say, well, that's because the digits are fragile, and that may be true. But we don't count it. Okay, so almost always the clinical trials exclude digit fractures and skull fractures. Now, some of the clinical trials also will exclude ribs, scapula, sternum, and sacrum. So again, you have to read carefully because they vary from clinical trial to clinical trial. But typically when we talk about a non-vertebral fracture, the left column is really what we're usually talking about. we're talking about the upper extremity, and it isn't just the distal forearm. We're talking about clavicle and proximal humerus. Pelvic fractures are part of the non-vertebral fracture group. And then the leg, the lower limb, the femur, and tibial ankle fractures. So again, when we're speaking about non-vertebral fractures, think about what is on the left, the 6 major non-vertebral sites, and the others probably not. Okay, 3 important points about bone density at non-vertebral sites and non-vertebral fractures. By the way, Noel, this looks good today. Did you do something? No, you didn't work hard to fix this? Anyway, thank you. It's fixed itself. So 3 important points. Reductions in bone density at non-vertebral sites predict non-vertebral fractures. That's pretty straightforward. A non-vertebral fracture predicts another non-vertebral fracture. A non-vertebral fracture predicts a vertebral fracture. And you can expand this to say a fracture predicts a fracture predicts a fracture. It almost doesn't matter where that sentinel fracture is, whether it's non-vertebral or vertebral. The risk of another fracture, as we talked about yesterday, is markedly greater. Yes, perhaps at the same site, so a vertebral fracture predicts a vertebral fracture with greater power than a non-vertebral fracture, but a vertebral fracture predicts a non-vertebral fracture. A non-vertebral fracture predicts a non-vertebral fracture, yes, a bit more powerfully than it predicts a vertebral fracture, but it also predicts a vertebral fracture. So it really kind of doesn't matter where that sentinel fracture is, whether it's vertebral or non-vertebral, because it is the sign that trouble is ahead. Fractures occur in subjects not known to have osteoporosis. We know that. We've talked about this yesterday. If that is a fragility fracture, by the way we define a fragility fracture, we don't need DEXA. You do not need DEXA to make a diagnosis of osteoporosis if that person has experienced the endpoint of the disease. And some people have said, well, why do you bother with DEXA if you know what the diagnosis is? The reason why we do DEXA is you like a baseline. It's a nice surrogate marker, and you want to track, you really should be able to track something, and you can't track fractures as an endpoint. So bone density becomes important, even if you've made the diagnosis of osteoporosis by the fragility fracture. And the next steps are to further evaluate the patient and take measures to prevent the next one. So this is a perfect logical sequence into how do you do that? How do you identify those individuals and not lose them? The big fractures, the hip fracture, winds up in the hospital. Not so big fractures wind up in the emergency room. And whether they're in the hospital or in the emergency room, they can easily get lost. So that is my introduction to Tara, who is our head of our fracture liaison service, and she's going to tell you about our experience in over how many years? 4 years?
4 years.
You've been doing it for 4 years? That's so amazing.
Crazy. It's so crazy.
I thought you had just come.
I know.
But Tara's been here for it. Yeah.
It.
So anyway, welcome, and we're
Thank you for having me.
Dial in. So you're on.
Yeah, this is great. Okay, hi everyone. Good morning. Thanks for having me, Dr. B. This is a great segue. Yeah. I mean, okay, now we all know about fractures. Now what happens? I'm what happens. Okay, so my name is Tara Keshnover. I am the FLS coordinator. We have a outpatient coordinator, Monica. She's part-time. She's not able to be here today because she has class and she has an exam today. And we both work for Dr. Ethel Cyrus, director of our Osteoporosis Center. So I'm going to talk a little bit about how we run the fracture liaison service here at Columbia. So as you may already know, fractures are super expensive. Medicare spent more than $5 billion to treat these fractures amongst senior citizens. Of the 30.2 million elderly Medicare recipients, and this is data from 2002, about 1.6 million have been treated for a fracture. That's less than 5%. An additional 7.2 million, which is around 24%, had osteoporosis but had not yet sustained a fracture. So this is data from the NBHA. So projected to like $2,008, the national cost of osteoporosis and fractures in the Medicare population was $22 billion, which is a lot of money. So osteoporosis was considered the 9th most costly major illness among the top 5% cost and Medicare beneficiaries. So this is a pretty expensive disease. So we have coordinator-based systems where secondary prevention with patients with fractures is key. So in the FLS, it's the most common intervention model that's been well reported and substantiated in literature. But the role of the FLS, depending on institution and funding, it can vary. So clinical trials have shown that better treatment outcomes happen when you have this comprehensive program that takes responsibilities from the inpatient or outpatient fracture and orthopedics to setting up of treatment in the osteoporosis center and endocrinology. And educational programs where you just send a letter to the primary care doctor, it's not realistic. It's not going to happen. Primary care doctor is going to get the letter and be like, oh, okay, great, and just throw it out. Unfortunately, a lot of primary care doctors, they're so, a lot of them are overwhelmed. They're worried with other more pressing medical issues, so a lot of times bones get swept to the side. And this is a conversation I have to have with patients when they're like, well, maybe I'll just follow up with my primary doctor. I'm like, no. And I'm going to talk a little bit more about that. So what do FLS services do that other service configurations don't do? So the first step is identification. So generally it's all women or men over the age of 50 who have fragility fractures, and they're assessed for risk factors for osteoporosis and future subsequent fractures. Second part is investigation. So as per relevant national guidelines, those at risk will undergo DEXA testing and fracture risk assessment. And we base our guidelines based on the NOF, the National Osteoporosis Foundation guidelines, which I'm going to talk a little bit more about in a few seconds. And then the third part is initiation. So when appropriate, osteoporosis treatment will be initiated after the initial contact with the fracture liaison service. So these are the 3 different types of models in fracture liaison services. So the first is type A, which is what we have here at Columbia, where we have a dedicated coordinator, which is myself. We ID the patients, we order the bone density, and we link them to care at the osteoporosis center and endocrinology. And then you could see like the rates for DEXA treating and osteoporosis treatment are both the highest. The second type of level, which is not as all in your face, is type B, where you just order the bone density and then you alert the PCP, and you could tell the rates for DEXA testing and osteoporosis treatment is less. And then type C, which is where you just alert the PCP alone, and you're looking at an osteoporosis treatment rate of less than 23%. And then type D, PCP is not alerted. So I think in these models, the patient is just educated and kind of left up to the patient to decide what to do next. So this is kind of how we have our FLS at Columbia. So we see any patients over the age of 50 years old with a bone fracture. That can include anything like hip, vertebral, wrist, proximal humerus. We even see some of the trauma patients, like patients that were like in a car accident or maybe may have gotten hit with a car, because it's New York City. Don't get hit by a car. And the reason why we do it is because we want to make sure that bone fragility was not a contributing cause to the bone fracture. And it's actually kind of funny when you interact with patients who, may have gotten hit by a car. They're like, no. I mean, I got hit by a car. That's why I have a broken hip. And I'm like, we know that, but we just want to make sure. Let's see. So at the inpatient or outpatient visit, the family and the patients, they're educated and given information the need to follow up for to prevent future about the patient's medical history and fracture history. And when we educate the patients, there's a lot that goes into that. So one of the main things we have to do is explain to them the difference between an endocrinology and an orthopedic surgeon. Most patients, and a lot of this is regardless of socioeconomic status, they have this idea, well, the orthopedic surgeon fixed my bone fracture, I'm good to go. Or they think that, oh, the orthopedic surgeon is going to order the bone density and treat my osteoporosis. So we have to explain to them like the different roles of the two different types of providers. And most patients actually don't know what an endocrinologist is. So usually we tell them, you know, it's the doctor that takes care of diabetes and thyroid, because everyone knows diabetes and thyroid. And then we add in, you know, the osteoporosis part in that too. We also explain to them what is osteoporosis. Seeing is believing. I use bone models. You know, I have the Forteo bone models. When patients see like the two models, they're like, oh my gosh, no, that's not my bone. And we've noticed that's kind of kicked patients a little bit more into like following up. Who's at risk? So we speak about like when bone quality starts to decrease, what are the certain risk factors? We also go over what are the consequences of osteoporosis. You know, you could have another hip fracture. You could be back at the hospital. You don't want to come back to the hospital. We tell them, you know, increased mortality rate. We tell them increased chances of permanently living in a nursing home. No one wants to live in a nursing home. So they definitely take this serious. Let's see. And also we speak with them regarding the importance of having regular bone densities, how often in the age. A lot of times in the FLS we'll come across patients who may have had a bone density maybe like 5 years ago or 10 years ago, and they're like, oh, I already had one. And we have to explain to them, listen, when you get to a certain age, you have to do it regularly because we want to know if bone quality is getting better or getting worse. Let's see. And we also explain to them what the osteoporosis evaluation entails. So you're seeing the endocrinologist. So here at Columbia, endocrinologists are specialists in metabolic bone disease. We let them know you're getting a bone density. We explain to them what a bone density is. Sometimes they're a little scared because they think, you know, X-ray, oh my God, it's a test. So, you know, we tell them it's low dose radiation. It's super easy. They're scanning your hip, your back, which is your vertebral column, and one wrist, and that kind of like calms them down a little bit. And we talk about the importance of, you know, getting the labs done after you see the endocrinologist. And that's something I'm going to touch upon more later. So here at the FLS at Columbia, our goal is to arrange the appointment here in the bone unit or the fellows clinic based on insurance. So the great thing is that almost every single patient we see in the FLS can get care as long as they have some sort of insurance, whether it's commercial insurance or Medicare or Medicaid. They can be seen here, which is great. And all of this happens after discharge because we can't see patients in the bone unit if they're still an inpatient in the hospital. There's no specific testing or treatment we do while the patient is in the inpatient orthopedic fracture service. The issue is because the residents and the attendings don't want to be responsible for those labs. So it's just easier that we do everything when they come to see the endocrinologist. If the patient has a PCP here at Columbia or they're already being managed for osteoporosis, we just contact the PCP here and we don't give them an appointment for one of our doctors unless the PCP here wants the patient to be seen by one of our doctors, because a lot of our PCPs do treat osteoporosis and they're pretty on top of it. If the patient's not able to come because of distance or they have an insurance that's not accepted, but literally it's only one insurance that's not accepted at the practice, we call the primary care doctor and we relay instructions on like bone density testing and the corresponding workup. So here at the FLS, so it's a clinical service. It's not research. Like even though we are gathering a lot of data, we definitely hopefully plan to write a paper one day about our experience, but this is not a research program. We have the support of orthopedics, which has been super key. They love us being there. They're great. They refer patients to us. We have their blessing to do this, so that's been super helpful. I work closely with the nurse practitioner that runs the fracture inpatient service, and we work with the attendings and the residents to get the patient seen by one of our endocrinologists. So we've noticed that when orthopedic speaks to the patient and tells them, hey, this is really important, you should do this, patients listen. And like I said before, we don't do any sort of inpatient workup, and we don't give vitamin D to the patients. And we hope to do this in the future, but the issue is ordering the vitamin D and having someone responsible for it as an inpatient. So that's been a little bit tricky with regards to vitamin D. And ironically, this reminds me when I speak with patients, a lot of times they're like, well, you know, I'll take vitamin D and calcium. I don't want any osteoporosis medication. And I tell them, it's not enough. So here are some numbers of our service. So up to date, we've seen a little under 1,100 patients, 808 inpatients because I'm full-time, and 278 outpatients. The outpatient fractures are mostly the non-operative fractures, so the vertebral fractures, the non-operative wrist fractures, those are the outpatient fractures. So we see overwhelmingly way more women than men, at 70% more women. Our age range is from 42 to 102 years old, and the 102 years old patient is actually the grandmother-in-law of a former attending that used to work here. So that was interesting. The average age of the inpatient is around 74, and then for men, it skews lower. I think it's because women live longer, so we have that to look forward to. And then the average age for the outpatient is 70. In regards to our community of patients, it's a mixture. We have a lot of immigrants and patients from the local community, so a lot of Latino, a lot of Dominican, Puerto Rican, Cuban, African American patients. We also have patients that come from the other boroughs, but mostly Bronx and Manhattan, probably because of proximity reasons. And we also have patients from the tri-state area, but it's mostly New York, the New York suburbs, and New Jersey, and the New Jersey suburbs. And then for race and ethnicity, mostly Caucasian and Hispanic, and a smaller percentage of African American. And the languages that we mostly encounter are English and Spanish, although we've encountered quite a few Russian, Hebrew, Chinese, and Korean, primarily speaking patients from the community, which is kind of cool because we didn't know these populations existed. And we do take a variety of different insurance. Like I said before, if they're not able to be seen in the private offices in Harkness, we have them seen in the Endocrine Fellows Clinic. So it's been a really interesting experience, and we've learned a lot. And it's teaching us about the challenges of how you institute this simple concept of FLS. It seems pretty, simple, fracture patient, educate them, get them linked to care, get them set up, and it's actually not that easy. So we're a complicated facility, unfortunately. We're a tertiary care center, so our patients, they're coming from all over. Their PCPs are not here. I wish we were like Kaiser or Geisinger, which are closed systems where everything is all at once, but unfortunately, that's not how it is here. So we've noticed that we cannot capture everyone. So permanent residents of nursing homes, unfortunately, we can't see them because the nursing home controls the Medicare. So theoretically, the patients are supposed to be getting the bone density and treated for osteoporosis. They're supposed to get that from the nursing home. Unfortunately, we'll speak with the nursing homes and it doesn't get done. So that's unfortunate. And there's also patients who lack decision-making capacity. So these are the patients that have dementia, and sometimes the family is available or not available to help get the patient in. Recently, we've noticed within our patient population is if we have a dementia patient that has a very loving family, a lot of times in the beginning they'll say, yeah, I definitely want to help my loved one. I want to get them treated. But unfortunately, what we come to see is a few months later, the patients start to deteriorate. They're not able to make it to the visit. So that's been very difficult. So in terms of fracture types, most of our patients had a history of a prior fracture. I want to say about 50%. 50% are actually hip fractures of all the total fractures. And then the rest are the non-hip fractures. So pelvis, femur, patella, ankle, upper extremity, humerus, clavicle, distal radius, elbow, vertebral. And the reason why we see all the different fracture types, including ankle and fibula and tibula, is we go by the NOF guidelines, which is anyone over 50 years old with a bone fracture should be evaluated for osteoporosis. And then we see a small percentage of periprosthetic fractures. And with the periprosthetic fractures, there's two types. Either they had a hip fracture before and then broke the prosthesis, or they got the prosthesis and then suffered a hip fracture. So we see those patients as well. So we've had definitely challenges to get patients to care. So a lot of our patients typically go to a rehab center, which isn't here. It's usually like off-site for extended periods of time. So timing can be tricky with the follow-up. Usually patients go away for rehab for like a month or 2 or 3. So we'll do the appointment like 3 months out. And we've noticed that having the appointment in the schedule is kind of like a way to like hold the patients in so that, they don't. Because if we call them, they're going to forget, they're not going to be motivated. So if we keep that contact with them and we have something in the books, they're more likely to come in. We do have a proportion of patients who fail to come see us. And we went to speak to orthopedics about this. And ortho was telling us, well, we can't even get them to come see us and get their stitches taken out. So that's not great. So they're also having issues with getting these patients back as well. A lot of patients don't want to think about it right now. When I speak to them about osteoporosis, they are so focused on the fracture. They're not thinking like big picture or future. They're like, I just want to focus on this. Leave me alone. So I'm like, okay, well, here's my information. Please follow up with me. And many times when I do follow up with these patients, a lot of times they're like, oh, yeah, I'm not ready yet. I'll call you back. And then they never call me back. Some of them they're just not interested in care, or they don't want like a new medical regimen. I try and explain to them that when you see the osteoporosis doctor, this is a visit that's only once or twice a year. So, it's not like cardiology where you're following up with a doctor monthly or maybe bi-weekly. Like it's once or twice a year. And some of them, they're afraid of taking a new medication. My jaw might rot off, which is not going to happen. So we do speak to them about different options for medication. And I tell them it's at the discretion of the attending physician who sees you. So I tell them, there's different options. There's a pill you take once a week. There's a shot done twice a year. There's an IV infusion done once a year. So I let them know this isn't something you have to burden yourself with every day. And I mentioned a lot of them are afraid of side effects, although I find it very interesting because they'll gladly take diabetes medication, hypertension medication, but for some reason when it comes to osteoporosis and bones, it's like, no, no, no. And a lot of them have lots of multiple medical issues, and like I said before, like bone health is just very low priority. Like they're focusing on the heart failure, the hypertension, and bones just get left to the side. There's also another thing I forgot to mention is some of our fracture patients, they may be coming from like suburbs that are maybe like 40 minutes or more away, and their local orthopedic hospitals are not able to treat their fracture pattern. So they send them to Columbia for like further management. And a lot of these patients, they're just here to just see the orthopedic surgeon and then just never come back. So we get a lot of those. So one of the biggest issues we have is patients' willingness to follow up medically. And, we believe it's a lack of understanding about the connections between their fractures and probable weak bones. There's this idea that Dr. B has said this all the time, like, doctor, I fell really, really, really hard. Like, if you fell as hard as I did, you would also break your hip. And I have to explain to them, well, no. Like if a child were to fall or a teenager, they're not going to break a hip, but someone over 50 is at a higher risk. Another issue is, I mentioned before that they have this idea that, well, ortho fixed the fracture and it's done, I'm good to go. And unfortunately, it doesn't work that way. And, I do let patients know, like, if you feel chest pain, you're going to go to the emergency room to get it checked out to make sure that you're not having a heart attack. You should want to treat bones the same way. And I mentioned before, there's patients that come here to Columbia for a specific orthopedic surgeon, and they don't want to come back. Like, they don't want to drive back to the city from like Westchester, New Jersey. We even have patients who live in Lower Manhattan or Upper West Side who just don't want to come up to Washington Heights. And we have patients that, you know, they think that if they eat organic and they stay healthy and they do yoga and they take vitamin D and calcium, that if they live this holistic, healthy lifestyle, they just don't need medication. And I have to break it down to them that the only way you're going to increase bone quality is through a pharmacological agent. A lot of them ask me, well, what about weight-bearing exercises? You know, the orthopedic surgeon told me. So I have to dispel the myth that weight-bearing exercises strengthens the muscle around your bone so that you're stronger and less likely to fall. But you could still fall. And a lot of them will tell me, well, I'm never going to fall. I'm like, you could always fall. You could fall using the toilet. You could fall leaving the bathroom, getting out of bed. Can't control what could happen. The best thing you could do is prevention. So here are some strategies we discuss with patients and like orthopedics in how to get a higher follow-up rate. So we tried adding the bone unit appointment to the discharge orders. We'll speak with the orthopedic providers to get them to encourage the patients at the post-surgery follow-up visit. Hey, you know, you have an endocrinology visit, definitely go to it. It's really important. Sometimes coordinators, myself or Monica, will show up to orthopedics, you know, bells and whistle in hand, another appointment card, and say, hi, do you remember us? You know, just a reminder, you have your appointment with us next month. Let's see. We also remind the patients, Lord knows how many times we call the patients to get them to show up. We call them, I think, 3 months before, then we call them a month before, then we call them a week before, and the day before. Yes, we're basically stalking them. So basically, you know, we're really committed to, you know, helping these patients prevent the next bone fracture. And, you know, as, you know, we have had success. So out of all the eligible patients, 60% do end up accepting an appointment and show up. Of that 60%, half of them are on treatment. When you look at the entire pool of who's eligible to come in, it comes out to like 20%, so the numbers start to get lower and lower. We noticed that 1 year after we did all this follow-up information to see like who's on medication, we noticed that 40% did not complete their labs. And one of the reasons is here at Columbia, the labs are in different buildings. And I think patients get confused, or maybe they're not motivated to have to take that extra effort to go to another building. So we came up with the idea to train me in phlebotomy. So I draw blood. It's great. I actually really enjoy it. Dr. B knows.
Yeah, great.
Yeah, it's fun. So that's been making things very easy. And, you know, we also started doing like one-stop shopping for our patients. So aside from getting the phlebotomy, like in the blood draw done here in the bone unit, for our fellows clinic patients, that they see them in a different building. So what we do is every Tuesday, we escort the patient from the fellows clinic building to come to the bone unit to not only get their blood draw, but also to get the bone density done. So we do it all in like one day. If they're seeing the attending, they automatically get the bone density 1 hour prior, but not with the fellows clinic. So we changed that, and that also increased follow-up rate and treatment rates. And then we're looking into cab fare, because we think maybe that might be an incentive into getting patients to show up. A lot of them are in so much pain, they're not able to walk around. So Dr. Cyrus is working on looking for institutions who are able to like fund that portion of the program. So we like to think that we're changing the face of what osteoporosis is, interdepartmental collaboration. We're getting orthopedics referring patients to us from the outpatients. Primary fracture prevention, we're getting people at Columbia to think about preventing bone fractures. We learned a lot in the last 3 years, and actually, 4 years, not 3 years. And, you know, we're defining some of the issues, and we're continually evolving. and looking for solutions. And that's it. Thanks.
Thank you very much.
Thank you. Any questions?
I'm curious, in those patients that do show up and need treatment, is there like an optimal time for them to get the treatment, like, or maybe wait 3 months? Because there's still some endocrinologists that have that stigma that, oh no, don't do it so soon after a fracture. So do we know about that?
Well, it's a complicated question. 2 ways of looking at it. One is to treat them quickly because of the urgency of treatment. The argument, on the other hand, is that, well, if you're going to use an anti-resorptive, which is often the case, will that delay healing because you're slowing down bone turnover? But again, arguing that point is the drive to heal a fracture is very, very powerful. And I would submit it's much more powerful than these drugs. So there might be some thought about there's a delay, but I don't think there's too much. The clinical trial, if you want to go back to the zoledronic acid trial, they waited a month after the hip fracture. So most of the standards of care are you get the patient worked up. It's going to take a month anyway before things settle down. A patient has surgery. Patient has to come see us, and by that time, a month's gone by. So typically, you wait a month before you institute treatment.
Yeah, and we, like you mentioned before, like we capitalize on momentum. So if we have a patient that wants to come in right away, we're going to make that happen, because it's really hard to like get patients motivated to come back to the hospital. In our practice, you have to wait a few months anyway to get an appointment. But if we have someone that's like fracturing all over the place or they're really motivated, we do find ways to like get them in sooner. Any other questions?
Amazing job.
So you say you see some patients that are uninsured?
We do sometimes come across patients that don't have insurance. So that's the one class of patients we're not able to link to care, because even in the fellows clinic, they still need to have some sort of insurance, and unfortunately, emergency Medicaid doesn't count. So usually for those patients, our previous coordinator for outpatient found that Harlem Hospital, which is one of the city hospitals here, they see uninsured patients. So we'll give them like the phone number and the address to go to Harlem Hospital and see one of the doctors there.
Eventually, but if you're seeing patients who have had an apparent traumatic fracture, and you are doing that, will you be able to say, once you get the data analyzed, among those patients versus those who have more pure fragility fractures, I'd be very curious to know what is the incidence of frank osteoporosis by T-score in the group that had an apparent traumatic versus non-traumatic?
Yeah, that'd be really interesting. And that's definitely something that we're noting in our data. We don't see too many of the traumatic injuries, like, getting hit by a car or in a car accident. The majority are fragility fractures. We do have some falling off stairs, falling off a step, and that's like in this weird gray area because it's not fragility, but it's not trauma either.
Right.
Any other questions? Great.
Thank you.
Thank you so much. Thanks for having me.
So we're going to follow up Tara's presentation. I'm going to give you some information about some of these closed systems that have really proved that FLS services work. And the Kaiser program in Southern California is the best example. Geisinger also. This is an open system. And the challenge to organize such a FLS without a clear protocol-driven system is enormous. And so I think we're a good example of how it can be done. Thank you.
Yeah. And I don't know if I mentioned before, so I'm not a clinician. I'm not a nurse practitioner. I'm not a nurse. I'm not a social worker. So a lot of FLS programs, they had like a physician or a nurse practitioner or social worker. I just have experience in clinical research, trying to go to medical school next year. So that is my background. So anyone can do this.
Your background is perfect. Thank you, Tara.
Take care.
Thank you. You do have to have that kind of personality. Can you imagine? I mean, you've got to get up in the morning and say, I have to, find these patients. This is my job. I'm going to do it. And she's amazing. She really is. And I think the success of such a program is a function of the kind of person you have, whether it's somebody who has a professional degree or not. That doesn't matter. It's your commitment and your sort of the enthusiasm that you bring to the work in Tara is a wonderful.
I'm not able to say no to Tara.
No, you can't.
Yeah, I can't.
I mean, that's exactly right. You can't say no to her. She's just great. Tara's point about language I find fascinating. New York City, I don't know the latest statistics about New York City and languages, but it's something like 200 languages are spoken in New York City, which is really amazing. I mean, just the idea that this city has such a rich cultural background based on people coming here and living here and finding communities that they feel comfortable with, and also in terms of integrating each other. So it's really a great feature of New York City. Okay, so the Kaiser implementation is the famous one, and Richard Dell, who is a semi-retired orthopedic surgeon, which is amazing. Richard Dell actually started this whole movement of an FLS, and it's kind of ironic that an orthopedic surgeon would do this, because we have been concerned about the need to educate and motivate our orthopedic community, and yet this whole thing started with the Kaiser Orthopedic Service. And Kaiser is a closed system. So you're in a system. Any of you are, tell me, is anybody in a closed system of care? Have any of you? Okay.
I'm a Kaiser patient. And the closed system is absolutely amazing. Like I'll get seen at my primary care doctor, and if it's like I need a specialist or something, they'll get a message. My primary care doctor will know. The entire system works like magic. My husband's ENT for Kaiser, so like let's say a primary care doctor feels a nodule because he's ENT. So I'm messaging the ENT. They'll message an endocrinologist within 1 week. They'll get like a biopsy. The biopsy shows some sort of pathology. Let's say it says papillary cancer. They go straight to ENT. They get a cancer call. It's just the closed system. No one falls falls into the cracks, and everything gets taken care of. They'll hound you down. Like if you miss your mammogram or something, you'll get multiple phone calls to come in.
Very well said. That's the beauty of a closed system. It is so efficient, and you don't get lost. If you need something done, it gets done within the confines of the system. So the system that was started by Richard was to address this issue of osteoporotic fracture, care gaps, and they developed a protocol by which patients would be identified at risk, and as well as those who had had a hip fracture, and looked at how you could get them in a therapeutic milieu so that they wouldn't have another. And I don't know exactly what the incentive-based versus punishment, nobody knows the details of how that worked within that system. So they started a number of years ago, again, led by orthopedics, and their goal was to reduce the hip fracture rate by 25%. Again, a closed system has access to all the data. It's all in a single database, so they could actually quantify their progress. We, as Tara mentioned, our system isn't nearly that rigorously controlled, but they can find out about osteoporosis medications, how many DEXA scans they've done, and the incidence of fractures, as well as the economic consequences. Again, if you have a closed system, you're more aware of the costs of care, particularly if you can expend a certain amount of money to prevent the fractures. You're going to save a lot of money for the system. So in this system, they found over that 7-year period a huge increase in the utilization of DEXAs, and concomitant with that, they initiated treatment by having the workup, including DEXA, a 355% increase in treatment initiation over this period of time. And in terms of hip fractures, a 49% reduction in the expected incidence of hip fractures. And the numbers that they think they prevented was like 1,500 hip fractures, and they may have prevented over 350 deaths. The cost savings, $50 million in 2011 based on the rough estimate of $37,000 of costs for each hip fracture. This is the percentage of individuals on osteoporosis treatment over the years. The men are in yellow, the women are in blue, and the total is in the light blue. And you can see the enormous increase in the use of pharmacological treatment over this period of time of the initial FLS. And in terms of, again, the actual versus expected hip fractures, the actual is in yellow, the expected is in blue. So you can see that they reduced the expected incidence of fractures over these these age groups enormously. So it did seem that there was an outcome here that was directly related to this proactive approach in this closed loop system. So there's another paper. Now this hasn't yet been published to my knowledge in full-length form, but this was an abstract at the ASBMR meeting just several months ago. And the question that this group asked related to mortality, because many of the FLSs don't look at mortality as an outcome. But the question was, does introduction of an FLS reduce mortality? And what they did was to compare two time periods in the same system. The usual procedures they followed over this period of time, and then they compared it with the FLS approach over the next 5 years. And this Kaplan-Meier curve shows that when they introduced the FLS service, the mortality, cumulative survival, was significantly greater.
But presumably everything else should have gotten better as time progressed. Like the time difference.
Yes. What do you mean by everything else would have gotten better?
Like maybe they also improved, I don't know, cardio.
Yeah. Oh, I understand. Yeah. So you're saying, yeah. So the whole medical attention may have had benefits beyond the FLS itself. Yeah, of course. And that's fine if you want to explain it that way. There's nothing, that's okay. But whatever else happened as a consequence of the FLS, these people had a lower mortality rate or an increased survival. And here's another paper that asked a question about, well, yeah, FLS works at Kaiser, and FLS works at Geisinger. But does FLS work at our system, an open system that's very hard to control? So what they did was to look at a very small private practice. It was a private practice setting, and looked to see whether this kind of system would have a beneficial outcome. So that it was a private, regionally based orthopedic practice, and they looked at Medicare claims databases among those who were or were not exposed to this kind of osteoporosis management service within a certain period of time. And what they showed was in the system where they captured these individuals, the recurrent fracture rate was lower, the time to recurrent fracture was longer, the rate of osteoporosis medication use was higher, and they had a greater utilization of bone density. So this abstract suggests that, yeah, you can, like our system, you can actually do well. You don't necessarily see good results only in a system that is controlled and protocol-driven. Okay, so that's a discussion about FLS, and I will say one other thing about FLS is that, of course, they become very popular. Many big institutions, medical centers have FLSs. the problem with an FLS is who's going to pay for these personnel? Who pays Tyra? Who pays Monica? And Dr. Cyrus, to her great credit, and this I'm just telling you this because this is typical of an institution like ours, we went to the orthopedic service and they said, this is a wonderful idea. We're on board. And they are on board. We don't have any money. So we went to our Department of Medicine. Great idea. No money. We went to the great New York Presbyterian Hospital. Everybody thinks this is great. No money. So the only way we were successful was, and one of the great things about New York and other cities like Los Angeles, Dallas, cities that have a tradition of philanthropy, is to go to someone who is so inclined and tell them what we want to do. And this happened. And one of our patients said, this is really important. We're going to support this program for X number of years. So that's how we launched the program, through private philanthropy. And many other services have been able to do it that way. So if you can get the money, however you can get the money, it is well worth it. Now, we're going now to change our hats. Now we're going to talk a little bit more about bone biology and these notions that we've talked about before. We've spent a fair amount of time talking about bone density and how important bone density is as a predictor of fracture risk. But bone density is one element of this discussion of bone strength, and the other has to do with what is called bone quality. And it's very hard to define what bone quality is. My dear friend Nelson Watts has said, bone qualities are anything that isn't captured by bone density. That's a way of thinking about it. But here are a couple other thoughts here. So bone quality relates to bone turnover, microstructure, bone size, and areas that we are less able to access clinically, such as microdamage, mineralization of bone, which is very different from bone density, and the quality of the organic matrix, namely type 1 collagen. Very difficult. But I think these points also speak, as well as the top points, to this composite term that we say bone quality or bone qualities. We've spoken about bone turnover, and this is a little bit more in detail about what we're talking about. This is the osteoclast coming in and digging a divot of bone. It's the initiation process of bone remodeling. The osteoclast will dig this micro unit of bone 3 to 5 weeks. It'll eat, and take a little chunk of bone out. We don't know what is the signal that tells the osteoclast you want to go here and take about this bone. Is it a micro damage piece that is now signaling the osteoclast to fix it? Or is it just a certain age related? Because the older the bone, the more stiff and poor it is. Whatever the signal is, the osteoclast comes in and digs this out. And then you have this reversal process where the mononuclear cell, the osteoblast, comes in and over a 3 to 5 month period will fill in this hole with type 1 collagen. And as type 1 collagen is laid down, ultimately that organic matrix is mineralized with hydroxyapatite. And at the end of this remodeling time, which is a 3 to 5 month period, there will be a restitution of that micro unit that has been remodeled. Now this is a cartoon of the aging adult. This is not a cartoon of you. It's a cartoon of me. And you'll see that at the end of the process, there is less bone here than there was at the beginning. And as a result, this bone remodeling unit is not in balance. It's in negative balance, either because there's too much bone resorption, these osteoclasts are juiced too much, or the osteoblast is getting old and isn't able to replace the hole, whether it's the same size hole or a bigger hole, depending on the osteoclast. Or more likely, it's a combination of both. The aging skeleton is resorbing bone perhaps too much, and forming bone perhaps too little. The end of the process is bone loss. That this is a micro unit of bone. Now, since we started about, oh my goodness, an hour and 10 minutes ago, time flies. How many units have I started in my system? How many units have I actually started to remodel? Take a guess. 1, 0, 1,000, 1,000,000? Do you think a lot or little? Well, or some good number. I don't know how many, but give me 1,000, maybe 500. A lot of units are getting started all the time. Now, suppose I'm in a high turnover state. So instead of 1,000 units that I've started in the past hour, I've started 10,000 units. If each of these units is a bad experience for me, the more I'm creating these bone remodeling units, the worse it is. The higher the bone turnover in an adult, the more likely it is that I'm going to lose bone. Very important concept. Well, this work goes back to Patrick Garnero and Pierre Delmas, where they looked at bone turnover by measuring bone turnover markers. And they showed that the markers themselves were independent predictors of fracture risk. Low bone density, we know, is also an independent predictor of fracture risk. And together, somebody who has low bone density and high bone turnover is at additional risk of fracture. Bone turnover then adds to our concerns, if it's high, in patients who have low bone density. You could say that even people with normal bone density, let's say an early perimenopausal woman, she may have a perfectly normal bone density. But because she's become menopausal and she's estrogen deficient, which is going to induce a high turnover state because of those cytokines that are no longer controlled well, that early postmenopausal woman with high bone turnover is likely to be more at risk for losing bone over time than she would have been if she were on estrogen or did not happen to be in a high turnover state. So if you look at this table, generally, the young person up to 20 in the formative years of life, bone formation will markedly exceed bone resorption. Where you guys are, you're pretty much balanced. You're normally turning over bone. You're not gaining. You're not losing. And then when you get a little bit older, even a little bit before the menopause in women, this begins to show a little bit more resorption than formation. And then, of course, in the accelerated period, early postmenopause, resorption far exceeds formation. And then it slows down a little bit, but still the system is out of balance. Okay? So that's the case. Now, some of you may say, well, I don't understand this. You're saying we're in negative calcium balance and the bone turnover rate is causing more negative balance. But what is the biomechanics of fracture risk when bone turnover is high? And it can be explained this way. These are these little bone remodeling units. And the more of these units you have, the more stress is going to be concentrated at these micro units. They're called stress risers. And so forces get concentrated in these little areas. And if you had a stress riser directly opposing each other, you would even be more vulnerable. So these resorption cavities are stress risers, and that's where bone breaks. Now, you can't see it because they're microunits. But the more you have these stress risers, the more you're concentrating stress at a vulnerable point. And that is thought to be the answer why these people are at greater risk, as opposed to someone who doesn't have much or any, where the stress will be more evenly distributed across the bone. So that is one explanation for why we think that high bone turnover is associated with increased fracture risk. So I think many of you know we have access to bone turnover markers. On the left are those that help us to decide about resorption, and on the right, markers that help us to access information about bone formation. So the CTX, the serum CTX, the fasting serum CTX, in someone who has normal renal function, in my opinion, is probably the best marker of bone resorption. The problem with the CTX is that not all insurances cover it. You have to use the code E85.8, which I use, to get coverage, and so far I've been lucky. I like the serum CTX. If you can't use the CTX, the urine NTX, not the urine CTX. The CTX is the carboxy end of the type 1 collagen that gets clipped off in the terms of bone resorption. The NTX is the amino terminal end of the type 1 collagen. And for some reason, and I don't know, the serum CTX seems to be better than the serum NTX, and the urine NTX seems to be better than the urine CTX. It just turns out that way. The urine NTX can be done as a fasting 2-hour urine. Doesn't have to be a 24-hour urine. And you can use it. I would recommend that you use whatever you can use and get familiar. You don't use both. But I tend almost always to use the serum CTX. In terms of bone formation markers, again, depending on what you can do, I like the osteocalcin. I like the osteocalcin. It seems to be kind of nice. It's a pretty good assay. The bone-specific alkaline phosphatase is more likely to be covered, so a lot of people will use bone-specific alkaline phosphatase. And the P1NP, which is the propeptide of type 1 collagen as it gets made, is a very sensitive marker of bone formation. I think in some cases it's too sensitive, particularly if you're tracking a bone anabolic agent. It shoots up and comes down very quickly. So I know the P1NP is very sensitive, the most sensitive. It's also the most problematical in terms of getting coverage. So I tend to shy away from the P1NP. I will use the osteocalcin or the BSAP. But just get used to one. Get used to one resorption marker, get used to one formation marker. And some of you may be trained wherever you are that they're not useful. The assays are very variable. There's a plus or minus 20%, 25%. So I think you can be told, and with good reason, these really aren't very helpful to you, and don't bother with them. I happen to think that they are helpful, and I do use them, and it does help me in guiding my decisions about how to follow a patient. So microstructure, we've seen a picture like this before. A little bit more discussion about what are we talking about when we're looking at microstructural deterioration. It's actually a very interesting topology. And the topology is that the horizontal matrix, if you want to resolve the microstructure into the horizontal plates and the vertical rods, you can do that. They're not actually all horizontal and vertical, of course. But the more horizontally oriented plates, they're called plates, tend to drop out more selectively, leaving the rods. And that's not good from a biomechanical point of view. Here's an analogy of a suspension bridge. This could be the Golden Gate Bridge. Those of you who are in the Bay Area, is that the Golden Gate? I don't know. It's not the George Washington Bridge. Doesn't matter. It's a suspension bridge. And the question is, what's holding up this bridge? The vertical rods, these two stanchions, or the suspension, the horizontal plates? What's holding this road up? What do you think?
Both?
Well, obviously both. You're hedging your bets. But if you had to pick which is the more structurally important element of the suspension bridge, is it the suspension or the suspension? It's the suspension. That's holding the bridge up. It's the plate, not the rod. What about this three-legged stool? Is it the rods, the legs, or the horizontal struts? If this rod, I know you've been on three-legged stools, and one of these is loose, it's a pretty rickety stool. Next time you sit on a stool and it's rickety, you'll find out that one of these horizontal struts or plates is loose, and that makes the rod very unstable. So similarly, we're dealing with a microstructural fallout of these horizontal plates. And this is a theorem that speaks to this discussion. And believe it or not, Euler lived in like 1650. Euler is like 500 years old. And he came up with this theorem of the bones of strength, not bone, but loads. And his point was that the shorter the distance of this vertical rod between the horizontal bars, the stronger the bone is to the second power. And this theorem actually applies very well to bone strength. The more horizontal plates you have, the stronger the bone is. The fewer horizontal plates you have, the weaker the bone is. So when we say microstructural disease and osteoporosis, yes, microstructural disease, but there's a certain orientation that speaks to loss of the horizontal plates as opposed to the rods. So do you recognize this guy? You saw him on Monday. This is Serge Kremers, who volunteered to be shown in our extreme CT machine. You're going to have a demonstration of it next week. The machine is shown here. You put your arm in, you keep it there for about 3 minutes. You have a brace, a little Velcro brace to keep your arm completely immobile. And then your arm comes out. And then you put your leg in, and you're braced to keep your legs immobile for about 3 minutes, and your leg comes out. And have you ever had, any of you had extreme CT? No? Have you had it yet? No? Well, I've had it. And the arm's easy. And I put my leg in, and it's very quiet in the room, and I started to doze off. After a minute, I don't know why. And my leg moved, and the technician said, Dr. B, you moved. You have to do the whole test over again. It's a very easy test, but the real challenge is not to move your arm or your leg. Now, when we're talking about microstructure, up until we had this technology, we were talking about bone biopsies. And David tomorrow is going to tell you about the transiliac bone biopsy. We still use it for research. But for clinical purposes, it's almost, I can't remember the last time we did a bone biopsy for a patient that we needed information about microstructure, because the combination of the bone turnover markers that gives us the dynamics of bone, that would be the tetracycline label part of a bone biopsy, and the more static features, that is microstructure of bone, we get with this machine. And this is what we can find on a woman who's perfectly normal on the left, normal DEXA, a 52-year-old woman who's getting to be osteopenic, and this person who has a hip fracture. And you can see the microstructural disease. You see the trabecular compartment that's really dropped out. It looks terrible. And this is also depicting a certain amount of increased porosity of the cortical compartment of bone. And I mentioned a few days ago, this technology has been refined even further to the next version of the machine, such that we can measure pore size, the number of pores, obviously cortical, the thickness of the cortex, the endocortical surface, and then all the trabecular indices, the number of trabeculae, the connectivity of the trabeculae, the separation of the trabeculae, the variability of the trabeculae. All these can be measured in this machine. We get about 14 cortical indices. We get about 14 trabecular indices. And I would say one of the real challenges of HRPQCT is we get so much information. And it's hard to know which one is the most important one. We haven't quite figured this out yet, but it is extremely helpful. We have databases, so we can compare our patient or our research patient with what we would expect in the terms of each of these indices. Okay, so we can access bone remodeling clinically. For some of us, we can access microstructure clinically, and I mentioned TBS as a less precise but helpful. You can get some index of bone quality with TBS. Bone size and shape, that's a little bit more difficult to do, but you can get a little bit of information by some of our technologies. And then mineralization is another thing that is not really accessible clinically. But what this is measuring how much mineral there is in the bone itself, not in the area that includes bone. In area that includes bone, there's area that doesn't include bone, and that's bone density. Areal bone density includes measurement of space as well as bone. But mineralization density is actually focusing on the mineral, only the mineral, with quantitative backscattered electron microscopy. And you can measure how much calcium is in that mineral itself. And this is an example of alendronate, an old study, 10 milligrams a day in those days. Alendronate was given as a daily treatment. And you can see that over time, 3 years after alendronate, mineralization density increases. And that's important. It's not just mineral density, but mineralization density with the anti-resorptives, particularly the bisphosphonates, can be improved. All right, so let us move now into a discussion of treatment of this disease. And these are the non-pharmacological approaches that all of us subscribe to. We touched on calcium, and we're going to touch on it a little bit more. Vitamin D, exercise, lifestyle. Smoking, of course, is bad for anything you can imagine. Can you come up with a reason why anybody should smoke?
Prevent preeclampsia.
I'm sorry?
Prevent preeclampsia in pregnancy.
Is that right?
Yeah. Smokers have less.
No kidding. So, thank you. Does that, so would you prescribe smoke? Oh, okay. Okay. But there, some of you, thank you. This is very, you and Tara will have a discussion this afternoon about this. There is another, I didn't know about that one, but there's a thought that ulcerative colitis. And I have a patient who had severe ulcerative colitis. He had been a smoker, and he stopped smoking, and he was on the operating schedule to have a colectomy. And about a week before, he said, he's depressed. My colon's going to take it out. I'm going to start smoking again. And so he started to smoke, and the flare-up just completely remitted. And he never had his colectomy, actually. He said, okay, I'm in. I'm smoking until something else happens to me. Actually, smoking does not improve the symptoms of ulcerative colitis. There was a very, very important study that was done and published in the New England Journal, a long time ago, about 15 years ago, that countered the impression that smoking may be helpful in ulcerative colitis. I'm not saying anything about it. I'm just telling you that the data do not support the anecdotal information. So, okay, we know about smoking. Alcohol, I saw a patient yesterday, and the typical history of my patients is that 95% of them put on the questionnaire, alcohol contact, 0. 95% of my patients do not drink alcohol. Half of them are not telling me the truth. I think they can't be telling me the truth. They think, and they don't want me to know, but they think that alcohol is bad for their bones, and so if they confess that they have a glass of wine at night, then I'm going to tell them not to drink. But that's not true. That's not true. Alcohol intake in moderation is actually protective. There's been some data to show that it's actually good for your bones. Up to a certain point, obviously, up to a certain point. Now, what is a certain point? The Frax tool has set the limit at 3 drinks a day. So that would be 3 glasses of wine, 3 equivalents of beer, hard liquor. Up to 3 is said to be not bad for your bones. More than that, and of course alcoholics, it can be very bad. But alcohol is not necessarily bad for bone. And we've talked about fall prevention. So calcium intake from all sources, 1,000 to 1,200 milligrams. That's what we recommend. From natural sources, we recommend. We use calcium supplements to supplement. But if patients can take calcium through foods, of course, we don't recommend it. I've never taken a calcium supplement. Never. Because I actually eat too much dairy. I love dairy. So I'm always eating yogurt and cheese. I've got at least 4 servings of dairy a day, so I get plenty of calcium through my regular food. If I were to take a calcium supplement, the recommendation is that you take no more than 500 or 600 milligrams at a time. And that is because absorption efficiency rapidly goes down as you take more than that at one time. So if you want to maximize the supplement, somebody's taking 1,000 milligrams, let's say, on a no-dairy diet, you would divide the calcium into 2 tablets, 1 tablet and then another tablet. And then the point I made the other day is we always prescribe the calcium supplement with food, and preferably a protein-based food, which allows you to take care of the need for acid if your patient is taking calcium carbonate. But in addition to that point, the bonus, for some reason, when you take it with a protein-based meal, you increase efficiency of absorption and get about 10% more in than you would otherwise. The carbonate is the preferred only because 40% of calcium carbonate is calcium. So you don't need as much the carbonate because the percentage is greater in calcium. The citrate is preferred by a lot of people. You have to take more citrate because it's only 20% calcium. The citrate seems to be better tolerated, although it's not ever been definitively shown. But patients who tend to have bloating or constipation, the citrate seems to be better than the carbonate. Some of these preparations have magnesium in them. And some of my patients have told me, well, doctor, you didn't prescribe magnesium. and I can't absorb the calcium without the magnesium. I'm taking a calcium carbonate with magnesium. And I say, okay, that's fine. But you don't need magnesium in the calcium pill to absorb calcium. You need to have magnesium in your body, but it doesn't have to be in the pill. And anyone who's on a regular diet who doesn't have an absorption issue is going to have a normal magnesium. It's very unusual to have hypomagnesemia unless you have a malabsorption problem or if you're an alcoholic or you're nutritionally deprived. The other point is the various carbonates. There are so many calcium carbonates on the market, and you can spend a lot of money on these pills or just get the cheapest. And so the question may be, is this cheap calcium carbonate formulation going to get absorbed? These pills are really hard. And so what you might say to your patient is take your calcium pill and put it in a half a glass of vinegar, which is acetic acid. And so that is the acid that will dissolve the calcium carbonate. And if it dissolves within a few minutes, then you can be pretty sure that it's going to dissolve in your stomach and you'll be able to absorb it. So I used to give that regular advice until a patient called me and said, "Doctor, I did what you told me. I put the calcium pill in the vinegar and it absorbed very nicely. But you didn't tell me it was going to taste bad." So sometimes your patients actually do listen to what you say, even though you didn't mean it. Okay, so we've talked about calcium carbonate, the citrate, generic versus the branded. If you go to the local drugstore, or go to the airport, the Hudson News in the airport, and you go to the vitamin shelf or go to the CVS, it's just mind-boggling, the number of things you can buy to improve your health. And even these are the people who don't want to take any medicines, but they bring in a shopping bag of these drugs. Some of these bottles of everything, total health, you're paying $100 for 100 capsules. Yeah.
Question, I've come across some of the gummy stuff that's sold by like pharmacy brand. Tricalcium phosphorus is listed as active ingredient. What's that about? Yeah, I don't know. Calcium phosphate. We don't typically use calcium phosphate. Phosphate's a calcium binder. So I am not sure about calcium phosphates. The triphosphates, they're different ionic forms of calcium phosphate. That's why it's tri-basic calcium phosphate. But I don't actually know whether they're better or worse, and because I don't know, and I don't know any studies, so I can't speak to that. But anyway, getting back to this notion of all these things that our patients are taking, my wife made this comment, which is worth telling you, and she said, Americans have the most expensive urine. All right, so we know about calcium, and vitamin D, we've talked about this recommendation under the age of 70. It's now 600 units, not 400, and over the age of 70, it's 800 units. Calcium is a threshold nutrient. Bob Heaney showed this. Up to a certain point, you'll improve calcium balance, and then you won't. That's what is meant by a threshold nutrient. And the point that Bob showed was for calcium, in a normal person, it's at up to 1,500. More than 1,500 milligrams of calcium, you don't gain any benefit. What you're going to do is just pee it out. So why take more than 1,500? This is how we've got this idea of up to 1,500, and now we've dropped it a little bit. But beyond this threshold, the calcium will be quantitatively lost and will not benefit your calcium balance at all. So I know your patients are telling you, "Doctor, don't you know that calcium's bad for the heart?" The cardiologists are very upset about this. They do the calcium score. They do the CT calcium score. You're taking calcium supplements. You must stop calcium supplement. It's going directly to your coronary arteries. And the data on this come from Ian Reid, who is from New Zealand. And he's published a lot of studies, individual studies, meta-analyses. And it's controversial. Many of them are not prospective studies, although there was one prospective study. Most of them are retrospective in their meta-analyses. The cardiovascular endpoints vary. Sometimes they're lumped, sometimes they're separate. And these studies haven't really addressed the amount of calcium. And many of these studies involved people who were taking more than 2.5 grams per day. Well, nobody's recommending more than 2.5 grams per day. In fact, we're not recommending more than 1.5 grams per day. So you need to be careful about this literature. It's true for anything. Too much of anything is not good for you. And that's probably true for calcium. But within the recommended range, there isn't a lot of evidence. In fact, a few years ago, a year and a half ago, Nick Harvey from the UK looked at women and men coming into the hospital, not for their bones, but for their heart. And it had to do with ischemic heart disease on the left or some other cardiovascular disease on the right. And as these people were coming in, they surveyed who was taking both calcium and D, taking calcium alone, taking D alone. And you can see that the hazard ratio with regard to those who were taking both or not was completely the same. So there was no association in men or women between intake of either calcium, vitamin D, or both on hospital-based admission codes for ischemic heart disease, any cardiovascular event, or death. So there didn't seem to be a differential by Nick's study. So calcium is good for you in moderation. Dietary calcium is preferred. We use supplements to supplement. And again, under 2.5 grams per day total intake, we don't have any evidence that it's really bad for you. And I think that that's a useful set of comments. We do not use 2.5 grams per day. I would suggest the maximum should be 1.5 grams. So calcium, drink your low or non-fat milk, eat your low or non-fat yogurt, cheese, and use calcium supplements only to supplement. Your patients who tell you, doctor, I can't drink whole milk because I have a high cholesterol. And skim milk doesn't have any calcium in it. You're going to hear this. Not true, right? Not true. Skim milk is just as white as whole milk. Actually, there's more calcium in skim milk than whole milk. Why? Because whole milk is 4% fat. Skim milk is 0% fat. Calcium does not like fat. Calcium is a water-soluble element. It doesn't get into the lipid layer. So if your 8 ounces of milk are skim milk, that's all water-based. More of it's going to be calcium than the 4% lot. So there's about 10% more calcium in a quantity of skim milk versus whole milk. Vitamin D, and get enough protein and exercise. And then this is the point I made about magnesium. Yes, we need to have adequate magnesium, but we don't have to have magnesium in the pill. In patients who have a tendency to be constipated, the calcium carbonate that contains the magnesium might be a good idea. Not to facilitate the absorption of calcium, but to help with the constipation. Because magnesium, as you know, can be a cathartic. So if you have a little bit of magnesium in the calcium pill, that might mitigate that potential issue with regard to calcium carbonate. Okay, other non-pharmacological recommendations, we've talked about exercise, preferably weight-bearing, but as I said before, I don't care what exercise they do. They should do something. Smoking cessation, avoid excessive alcohol intake, and do as much as you can to prevent falls. Tyra made the point about falling. So I always ask this question to this group. They're all young. Honestly, give me a hands up. How many of you have fallen in the past year? Yeah, it's amazing. It is amazing. We all fall. At least half of us, more than this group, almost all of you, have fallen in the past year. It's amazing. It's a group of particularly clumsy fellows. But even if you were not clumsy, about half of you, we fall, we slip. We aren't paying attention to where we're going. And it is said that those over the age of 65, there's a 50%, I think it's higher. Because if you're all well under 65 and you fall, the over 65s are more likely to fall. So we all fall. That's it. And we'd like to prevent falls, but I don't know whether we can. So there has been an idea to use hip pads to prevent, not to prevent falls, but when we do fall, if you're wearing hip pads, you will fall on your trochanter and you'll soften the blow and perhaps not break your hip. The problem with hip pads is that they give you size, And I don't know about this, but women, maybe more than men, I shouldn't say it that way, but maybe women more than men worry more about their size here than men do. And they won't wear hip pads. They won't wear hip pads. That has not been, compliance has been a big issue. And that's one reason why it's been very controversial as to whether hip pads help to prevent hip fractures. They don't prevent falls, but do they prevent hip fractures? And one of my colleagues suggested, and those of you who are so inclined may think about this, can you design a hip pad that's like an airbag? That is directly flush right here. It doesn't add anything to your side. And as soon as on impact, it explodes and it protects you. Nobody has come up with this idea yet, but you should think about it, because if you do, you can just retire. You can patent it and you'll be rich. All right, we're going to now talk very briefly now, but we're going to get into big detail next week about the drugs. So this table is the up-to-date table on the drugs we have available, the FDA-approved drugs we have available in this country for osteoporosis. The pluses reflect the evidence that the drug is effective at vertebral, non-vertebral, or hip sites. And you'll notice that estrogen gets +++. You'll notice that 3-bisphosphonates get +++. Abandronate gets a plus. But first, notice that every drug gets a plus for vertebral. That's because they have to be a plus for vertebral, or else they don't get approved. But now you see a difference here. Abandronate doesn't get a plus for non-vert, doesn't get a plus for hip. And this is a little bit of an asterisk, because only in the post hoc analysis of the Abandronate study was there some evidence that those whose femoral neck bone density was less than -3, was it effective in non-vert fractures, but was post hoc analysis. That's why the FDA does not allow the statement to be made that Abandronate reduces non-vertebral fractures. By the way, are you all familiar with these generics? Do you want me to tell you what they are? Because, I mean, we use them, but Alendronate is, Fosamax. Risedronate is Actonel. Zoledronic acid in this country is Reclast. In Italy, it's Aclasta. Abandronate is Boniva. In Italy, it's Bonviva. I know the European pronunciations. Denosumab, is Prolia in both countries. Not Prolia. Don't say Prolia. It's Prolia. And that's true. It's Prolia. Don't say Prolia. Raloxifene is Evista. Is Evista in Italy? Yeah. Calcitonin is calcitonin. Yeah. What else? Anyway, teriparatide, is Forteo or Forsteo.
Very good.
Thank you. Enalapril is Tymlos, right? No, you don't know. You don't have it. You don't have it yet. You don't have it. Europe doesn't have abaloparatide yet. What? We don't. It's not because we don't have it. Clodronate. We don't have clodronate. Canada has clodronate. I'm sure. Yeah, we don't have clodronate. We've never had clodronate, so it's not on the list. You have clodronate?
It's the favorite one of
Really? Wow. It's the Italian politics. I think that must be it.
Because there is lidocaine inside, so people feel better for the and everyone uses clothing.
It's amazing. Well, we don't know clodronate. We don't know clodronate at all. Okay, so DMAB, we call it affectionately DMAB. It gets pluses across the board. Raloxifene, vertebral. Calcitonin, vertebral. Teriparatide and abaloparatide gets pluses. Now, when you see the negative dashes, don't misunderstand this. Doesn't mean that the drug doesn't reduce hip fractures. That's not what the dashes mean. It means that there's no evidence that the drug reduces. So it's very difficult to show hip fracture efficacy. The studies often are not powered to be able to say yay or nay. So we need to be careful by saying raloxifene doesn't reduce non-vert or hip. All we can say is that there's no evidence. Okay? That's the way you should think about it. And very importantly, for the osteoanabolics, the studies were much too small, much too small. The teriparatide study had 1,673 patients. The abaloparatide study had 2,500 patients. Not nearly enough, knowing what we know about the incidence of hip fractures, to power a study to show that it is likely to reduce hip fracture. In fact, the abaloparatide study, I don't think they had one hip fracture in the whole cohort. So again, be careful. So we're going to talk about anti-resorptive therapy. They all, without exception, reduce bone turnover. Very, very important mechanism. They affect the osteoclast. They affect the osteoclast in very different ways. But ultimately, they're anti-resorptive because they block bone resorption. They stabilize but not increase microstructure. Many of them, but not all, increase mineralization, okay, not just bone density. But as a consequence of these effects, we see an increase in bone density. A good example of this is alendronate. On the left, you see the resorption line. You can't really see it that well, the line most to the left. The drugs block resorption very, very quickly. Some, like within a day, you can see changes in the resorption marker. And then later, these drugs will also reduce bone formation because bone resorption and bone formation are linked with very few exceptions. The time difference between the rapid effect to reduce bone resorption and the later effect to reduce bone formation gives you a little bit of a window whereby bone balance is going to be positive. You're reordering that negative calcium balance. And as a result, bone density is going to go up. Bone density in all the trials we're going to talk about, without exception, the lumbar spine will show effects first. I don't think you'll ever be able to show me a study where lumbar spine did not go up first. And it also goes up the most. So why is that? Sorry? Well, yes, you're sort of right. You said more trabecular, but what does that mean?
Is it more active?
That's right. So it's more active. Trabecular bone has much higher bone turnover. If you're turning over the vertebral spine 10 to 15% per year, so trabecular bone has high bone turnover. and you depend on bone turnover because these are anti-osteoclast agents. So you got to hit the osteoclast. And if you're hitting a lot of osteoclast because you're in a high bone turnover state, you're going to affect change much faster than at a distal site like the distal arm, where bone turnover is 1% per year. And the hip is kind of midway. If there were a line a data set here for distal radius, it would basically not go above baseline. So this is typical. Hip density goes up, yes, and you typically can see a statistically significant increase, but lumbar spine always shows faster changes and changes to a much greater degree. So here are all the anti-resorptives. I've taken away the osteoanabolics. And as I mentioned before, they all share in common the effect to reduce the risk of vertebral fracture. So a couple of comments about estrogen, because Tara's going to talk about this in greater detail. But this is from the Women's Health Initiative, very, very important study that looked at estrogen in many different ways, but we're going to focus on fractures. And the estrogen and progestin arm shown here, or the conjugated estrogen arm alone, showed a reduction in clinical fractures in both of these arms to a significant degree. The clinical fractures were essentially non-vertebral fractures. There were only 10% of these fractures were clinical. I have somebody's calling me. Oh, I see. Yeah, I'll wait. And so the data are pretty good in this study showing reduction in clinical fractures. And if you look specifically at the hip fracture incidence, there was a 34% reduction in hip fracture. Now, this is the basis for why we say estrogen, one of the reasons why estrogen is effective to reduce vertebral, non-vertebral, and hip. The cautionary note here is that the Women's Health Initiative was not taking women who had osteoporosis. And the average T-score, as I remember, was like -1.3, -1.4. And the average age was 62, 63. And even so, estrogen reduced vertebral, non-vertebral, and hip. So the not the pundits, what's the word for these people? The name is not coming to me quickly, but the persnickety people. What I'm trying to say, forgive me, I don't get the word here. What I'm trying to say is that the nitpickers are saying the drug was shown to be effective in non-osteoporotic women. What's the evidence that it works in osteoporotic women? And I say to myself, come on. If you have a drug that's working in an osteopenic population, it's hard to believe that the drug would not be effective in a higher risk population.
You said that the mean age was 60?
The mean age was 60, 62, 63. There were women in the first decade, too. And there have been many, many post-hoc analyses. And I think Tara will get to this, about cardiovascular issues, breast cancer issues in the younger versus the average. But we're not going to talk about that right now. But the study, I think the average age was 62, 63. OK, well, we know about efficacy. And estrogen's a great, great drug. It reduces incidence of colon cancer from the WHI also. But here are the issues. And that is why estrogen got a bad name. And it goes through cycles, you know. I think we're in a cycle where we're more positive than negative these days. But not too long ago, oh, my God, no one even wanted to talk about estrogen. And there are issues here. So you do have to select your population. Who is eligible? For whom are you putting at risk in one way or another? And of course, if there's a risk profile here, you're not going to use estrogen. You're not going to use estrogen in a woman who says, I don't want estrogen. You know, you can't force people. But I do believe in the early postmenopausal woman who, I have a number of such women I'm taking care of now, and we have an active discussion about using estrogen as the way to prevent bone loss, because it is a preventive, not necessarily a primary therapy, although I think it can be used as a primary therapy. But it is sort of has a little bit of a shroud over it because of some of the potential risks that patients may be exposed to. So it's very controversial as to whether or not we are going to use estrogen and who we're going to use estrogen for. So I'm going to just spend another 5 minutes because I have to go somewhere soon. But I just want to touch a little bit about the selective estrogen receptor modulator. I'm not going to talk about tamoxifen. I'm going to talk about raloxifene. Raloxifene, this comes from the Moore trial. And clearly, from the Moore trial, there was a reduction in vertebral fractures, both in those without pre-existing vertebral fractures as well as those with pre-existing vertebral fractures. You all know also that raloxifene has an indication for the prevention of breast cancer. So in certain individuals, Evista or raloxifene might be particularly effective. But here is where we are not as happy about raloxifene, and it has to do with the data for non-vertebral fractures. This is from the original trial, looking at osteoporotic non-vertebral fractures, hip fractures, the treatment group versus the placebo group, and out to the 3 years of the clinical trial, the curves did not separate. And the extension of this trial, the core extension, went on for 8 years, and the curves are exactly the same. So out to 8 years, there was no apparent effect of raloxifene on non-vertebral fractures or hip fracture. Bless you. And so I'm not saying that the drug doesn't work at non-vertebral or hip sites. I'm just saying we don't have the evidence. So we have issues as well. Increased hot flashes, cramps. People can complain of cramps, muscle cramps, leg cramps, shoulder cramps. DVT risk is similar to that of estrogen. Risk of pulmonary embolism, similar. Risk of stroke is similar, but there seems to be an increase in mortality associated with raloxifene. And we talk about a limited osteoporotic spectrum. But it improves bone density, reduces vertebral fractures, and again, this issue about breast cancer is noteworthy because if you have a patient, there is a patient that you are going to see who's early menopausal, who has selective reduction in vertebral lumbar spine bone density, whose hip density and distal radial density looks pretty good, and who may be at risk for breast cancer by a first-degree relative or what have you. Well, raloxifene would be perfect for that kind of patient. Perfect. 60 milligrams once a day. So I think there are patients who would benefit from raloxifene. But in general, we have other drugs that give us a more broad-based efficacy profile. And for our patients who have more generalized bone loss, we're more likely not to use raloxifene. We're more likely to use one of the other drugs.
Dr. B, will it be covered later, like duration for if you start something like raloxifene?
Well, raloxifene, I'm not going to talk about duration. That doesn't seem to be a big problem. The other drugs we do have to talk about.
Yeah, of course.
That is a major problem. Okay, I am going. Any questions? Happy to talk about any more. Okay.